Hello, my name is Cornell Wright. I am currently serving as the Executive Director of the North Carolina Office of Minority Health and Health Disparities out of the Department of Health and Human Services, where Mr. Cody Tinsley serves as Secretary. Thank you for having me, and I apologize for not being in person, but I wanted to still be able to share some information with you about health equity. So I'm going to treat you as if you are here, or treat me as if I'm there. So if you have any questions, please feel free to put them in the chat, and hopefully somebody will be able to answer them. So as we get started, go ahead and pull up my slides. And so I'm just going to take a little bit of time and talk about health equity in context. And from there, we'll dive into a few things. So this is the current makeup of the office. The office is celebrating its 30th year this year. And we're also in a bit of transition. So we're actually transitioning from the Office of Minority Health and Health Disparities here in North Carolina to the Office of Health Equity. And so more information to come on that transition, but the work will still continue to achieve equity and do so within partnership across the state of North Carolina and beyond. So I want to start with a basic foundation of what health equity is and the connections that we link to it. And so when we think about health equity, we're talking about the opportunity for everyone to maintain, sustain good health and well-being. We tend to talk about it in the context of not just making sure people survive, but thrive while doing so. And some of the things that prevent that from happening, we call the health inequities. And the way we measure it all, we're looking at comparison of outcomes, one group to another, or one disease state to another. We call that the disparity, that measurable distance or that measurable gap that we see. And so it's so important that we know these terms that we hear so often or we say ourselves and how they are similar yet different. And then we look at the way that we connect to it all, those factors that can greatly influence the way we live, work, play, engage, and worship, or not worship. We call those the drivers of determinism. And, there's so many different things that are connected in so many different ways that we'll kind of get into in that conversation. But I do want to point out that when we think about the larger piece of this, policy is such a huge piece. And so it used to be the train of thought that we wanted health in all policy. And that's a good start. But now we need that lens of fairness to go with those policies. So we want to make sure that we're fighting for and achieving and promoting health equity in all policies. We tend to think about the words that are similar but different, the phrases that are similar or different. We really stop here and talk about equality is not the same thing as equity. When we get to that conversation, we see that equality is giving everybody the same thing. Equity, we meet people where they are based on their need. But then there's two other areas that we have to jump into and consider in this journey. So health equity is a journey, it's a spectrum, it's a way of life, it's a lifestyle. And so liberation, you see here that we get rid of the structural barriers and the enhancements, and people are able to see the game. But then inclusion is such an important piece here. Not only are we connecting people to the resources they need, but we also have them a part of the process. And so it's often said that people need a seat at the table, but people also need a voice and value with that seat. And so if we don't necessarily understand that as a driving piece of this, what are we really doing? So we want to make sure that we're including people and being able to help achieve equity in their own communities. We all have some barriers that we have to deal with in terms of what we see and what we face. And so, some of these are not new. Most of them are probably not new to any of us. But, access and opportunity is an issue. Transportation is always been a thorn in the side of us progressing at times. We're seeing a lot of issues with workforce, especially with coming out of the pandemic. We've seen a lot of changes happening. So workforce is something to definitely keep our eyes on, as well as the financial and educational issues that have, I don't know about you all, but student loans is a real thing for many of us. And then fear and mistrust, myths and misinformation. These are things that we've seen go on, more recently, more than usual. But it's interesting how these play a role. We start getting more into some of the nuanced complexities of what we're talking about. We think about from a provider or a healthcare side or a patient side, this issue of people being labeled. A couple of labels that come to mind are non-compliance or patients being non-compliant. Another, thing that we have to deal with. And what's so sad about this is because, sometimes people are not adhering to medical advice, not because they don't want to, or maybe because they don't understand, but maybe it's not, feasible for them. There's issues of trust there sometimes as well, where people may not feel comfortable with their provider enough to share what's going on with them. And so we also see this other label of what they call frequent flyers, or people who are engaging often with health systems of health and healthcare. And so we've heard many stories about getting to root causes to really help prevent this and more innovative care now. But there's still a lot to be done in this space. Another thing that we see, especially when we think about the provider side, or a lot of cases in practitioners, this whole notion of people practicing colorblind care, people saying that they don't see color, they don't see color in their patients. And that could be a problem, because we may need you to see color. We may need you to see that there are differences and nuances with people that you serve or care for, and that your experiences don't dictate everybody else's experiences and vice versa. But we don't want to be blind to the fact that people are treated differently because of their skin color, or where they're from, or their ethnicity, or how they talk. And so that's important. Another piece to tease out is geographic makeup, or where you live. There's been studies, multiple studies, that talk about how your zip code can make you sick, or can be killing you, or lessen your life expectancy. And this, also goes back to access and opportunity, in a sense. And one of the, those issues connected to that too is, access to healthy foods. And we see this a lot: the food deserts, food swamps, and how that plays out in communities, and even food disinvestment, where those resources are intentionally taken out of those communities. And then just the lack of plain language. One of the biggest things that we could talk about, besides trust, is the lack of plain language, and how, if people can understand what we're talking about, then we really can't expect them to change some of their habits or behaviors to be more healthy. And so we got to do it in a way that they understand and they don't get lost in our message. When we think about these drivers in terms of health, we see so many of the ones that stand out often. The environmental issues, education, housing, transportation, health and healthcare, food and nutrition, violence and safety, and poverty. These are important issues that come up often in our communities. And what if I told you one of the biggest drivers and determinants of health is not even one that we talk about enough, and that is trust. Trust is so important to raise up as an issue. And so when we're thinking about how we work together, how we work with people, how we connect with people, how we engage with them, trust is a huge factor. You're not going to really connect with me if you don't trust me. And if you don't trust me, you're not really going to be really hearing or connected or engaged with me or what I'm saying, or what I'm prescribing or what I'm asking you to do to improve your health and well-being. So, and the other piece is not just trust, but trustworthiness. And in our organizations, we have to practice trustworthiness and be transparent and making sure that we're working with communities at every turn, working with people that can help us, and not just the same people every time, but also making our partners more diverse and more connected in other areas that we normally don't do, and that's important. And really think about what influences health equity. There are so many things that we could do a whole another presentation on just this slide alone. But one of the biggest ones that I'll raise up is policy. So when we think about policy, it's more than just what we see here, right? We think about national, state, and local laws, policies, and statutes, and rules and regulations that govern us. But what about those unwritten rules, right? What about that policy that you grew up with, like me, that says what happens in this house stays in this house? That policy has been killing communities for years. We don't know what's going on in our communities and our families. We go to the doctor and we ask about our family health history, and we don't know. And so part of the problem is when we are thinking about policy, we have to widen that lens a little bit and think about how do we govern ourselves by rules that may be formal or informal, as well as the more connected issues of policy that we tend to think about. Another issue that comes up is this conversation around racism. And so when we talk about racism in this context, we're talking about systems of unshared power and how those systems perpetuate themselves upon themselves by not sharing power and creating other systems of advantage for some and disadvantage for others. And this is important. So Dr. Kamara Jones came out with these allegories on race and racism. And he's got a TED talk that's like hyperlinked in here that talks about these theories, and they're amazing. So as a homework assignment, as a virtual homework assignment, go look up Dr. Kamara Jones and her TED talk on the Gardener's Tale, and you'll see all these different allegories on race and racism before you get to it. But she closes out with it, and it's so masterful. So I won't even try to do it myself, but it's so important because it talks about the different levels of racism and these systems of unshared power and how they affect us in so many different ways. And so when we think about racism and systems of unshared power, we also take a slight detour to talk about trauma and health. And we're hopefully coming out of a pandemic right now, but a good friend of mine, Dr. Michelle Laws, talks about the silent pandemic of mental health and behavioral health. And so another thing she talks about are these issues that we see that have gone unchecked in our society, and how that's playing out more so now than probably we've ever seen before. And so a big piece of what we saw, especially during the pandemic, was these conversations about historical trauma and triggers, right? So we hear about Tuskegee, we hear about different studies like in Cincinnati with the radiology studies. We hear about Henrietta Lacks and the stolen HeLa cells. We hear about eugenics, especially in this state. And then, so those post-traumatic, stressors are talked about in a historical context. But what about, and this is also about what Laws talks about, what about those daily ongoing traumatic stressors or the dots? How do we connect the dots? For many of us, no matter where you come from, what you do, for many of us, there's stress in just getting in your car and driving and having police lights come behind you. Even if you know you didn't do anything wrong, there's still stress there. And how does that turn your stomach each time it happens? Even though they're not coming for you, they might be going around you or having you pull over, but there's still an element of stress there. And so that's part of the daily ongoing traumatic stressors, as well as the traumas and triggers that we face each day, and that plays a role in what we're dealing with. Another issue is that of bias, right? And so bias is very interesting, and this piece here is pretty much an article that shows an experiment that took place in Florida, in Miami-Dade County, where a school system tried to take out as much bias in their gifted and talented programming as possible to see, what would happen. And so students that normally weren't even able to test for the gifted and talented program were given a chance to test, and the results were amazing. And why so many students that often got overlooked or put in remedial courses ended up really scoring higher than some of the students that were already in the gifted and talented program. So people really had to look at their policies. Administrators and organizations have to look at their policies and behaviors based on bias to see were they actually holding people back based on bias or giving people an equitable opportunity to succeed. So one of the things I wanted to just share with you was the importance of how you respond to things. And one way we responded during the pandemic in its early stages was really getting a hold of and defining what we meant by historically marginalized populations, and then mobilizing that into a work group. And I'm very proud of the work that we've done in this space. And so when we talk about historically marginalized populations, or HMPs, we're talking about individuals that individuals or groups of people that may not have always had a fair shake or a fair chance or representation or opportunities to benefit as others have. And so it's not just about race and ethnicity, but those things are important, but it's also looking a little deeper at like so many other factors, like where you live, like are you in a rural area versus an urban area, how you identify or how people or how systems may identify you. And are you part of a disabled community? Are you a veteran? Are you homeless? Are you part of a refugee migrant population? Are you part of a different community based on gender identification, sexual orientation? So many different other factors that we haven't really fully named out, even based on their social economic status. And so how do all those things, even your religion, how do all those things, including language, play into how people have been historically left out of opportunities and conversations, and how can we change that? So what we did at DHHS was start this historically marginalized population work group, and then really start leading with earning, building, and sustaining trust. And so, it's so much to deal with that, we would be here for millennia still trying to deal with these issues, but you got to start somewhere, right? And so as we lead with equity, we lead with trust. And we have to earn it, we have to sustain it, maintain it, build it, and make sure that in those processes, people are included. There's diversity in the process, and people at the table not all look the same or from the same areas. And then how do we connect those dots? How do we actually even heal some wounds from things beyond our control, or things that have been in our control? So part of what we did to earn trust was engage with leaders. We had a good handle on some of this because the work of our office has always been connecting to our leaders across the state, especially in our faith communities and our community-based organizations, schools, our education partners, and beyond. So the list of partners that we normally engage with is vast. But then also, how do we engage in a different way? A lot of stuff we used to do was face-to-face, and now you had to add the technology component and connect with people that don't always have internet connection. So how do you go about that? So that's been interesting. But for those that could benefit from internet connection, we did a lot of pivoting there as well. And so we hosted fireside chats and cafecitos, which is like a Spanish version of the fireside chat. We've also produced different videos and PSAs and shared others. So we did a huge investment in media, and also connected with trusted sources and trusted messengers to help spread our message and their message as well. And so one of the biggest pieces that came out of this was mobilizing our on-the-ground workforce. So our community health workers, our case investigation, in contact tracing staff, and our health educator partnership that we connected with our community organization. This is so important to move that work forward. So we started out really creating this H&P work group based on addressing COVID and really connecting with these partners from various various sectors across the state and beyond. And then what we ended up doing was changing the focus of the work group into kind of how it's looked now, and it may change some more to focus more on equity and COVID, but more so leaning more into the equity space as we're hopefully getting out of COVID, right? So now, the way it looked is, we have 5 work streams within the work group: prevention, testing and screening, community engagement, health equity education and empowerment, which under that we have a health H&P Academy where we work with our high school and college students, and then we have economic opportunity and employment equity work stream. And in that work stream, we look at our procurement practices and our hiring practices and retention practices, because you have to have a workforce that is reflective of the community that you serve, but we also need to have vendors that are also reflective of the community that we serve. So a lot of work going there. When we think about incorporating health equity, it's a few things that come into play. And so understanding there's a difference, but similarities and connections with racial equity and health equity, and understanding that culture and language play a major part of what we're talking about. And why that's important is because if people can't understand what you're saying, if we can't translate things in languages or even use plain language in this space, then our message is going to fall flat. And then making sure that the tools that we're using are used appropriately. A lot of tools have been used from the equity space, and some people think they're like icebreakers, but they're not. These are really important tools that have purposes. So we got to make sure we're not just trivializing these tools. And then making sure that we have the lens of fairness, or this equity-informed lens, in everything that we do. Before the pandemic, our office started doing, long before I even got here, they started doing health report cards for the state. And then we, in 2018, transformed that report card into a health equity report. And now it's going to become a health equity dashboard, much like the one that you've seen during COVID, hopefully, with similar structures, and being able to, capture things in that vein that has been so helpful to share information. And then, the COVID dashboard now has gone into a more weekly cadence for things, as hopefully things have kind of calmed down and stay calm. Another thing that we've been using is this toolkit. And this toolkit has been helpful for engaging with historically marginalized populations and helping organizations and community-based organizations, health departments, and others connect with each other and not have to just be connected in time of crisis, but have a consistent dialogue. And this helps give steps and resources to do that. Another thing is making sure that we publish what we do. And so there are some North Carolina medical journal articles. One that I authored was called In Search of Equity. Kind of gives you a more contemporary context of the history of health equity work in the state. And there are some other ones that are connected to our historically marginalized population work in the work group, and other editions of the North Carolina Medical Journal. And so hopefully you can check those out. And then also finding different ways to incorporate your messaging and making sure that we just don't do a one size fits all approach. And so one way we've been doing that is, finding ways to reach your audience. I did a TED Talk in a unique way. And the presentation I did that led up to the TED Talk was done at a conference in 2016, where I was a closing keynote for this conference. And in my closing keynote, I had a DJ and a spoken word artist as a part of that. And so it just gives something different, a different element. It captures people's attention to understand why this is important, but we can also not just use the same methods to reach new people. So as I close, I want to leave you with this quote, but before I do so, I just want to thank everybody for your patience and your time and your attention. It has been, it's just been some interesting transitions, even for me personally. As I close here, I will be moving on to a new position. And so I want to make sure anything you need, I'm still be available. I'm moving to take a national position with a national nonprofit as their first ever Chief Health Equity Officer. And so more news to come on that soon. But I want you to know that this fight continues. This work is important. And also know this, that health equity is not the sole responsibility of one individual or one agency, but the collective responsibility of us all to do better, to be better, and to help others. Thank you so much. I wish I could be there. Thank you for this opportunity. Hopefully, I've said something that have a good one.